Good morning. I think it's kind of right on time, so we'll get started. My name is Amy Neville. I'm a bariatric surgeon here in Ottawa at the Ottawa Hospital. I'll be chairing this morning's debates, which is looking at which operation is potentially the best operation in bariatric surgery. And I think this is one of the things that those of us who work in the area remain excited about. This is an area that continues to evolve, and it's interesting that, so many years after the widespread popularity of bariatric surgery, we're still debating what the best operation is. So I'll start by inviting our first speaker, who's Dr. James Ellsmere. Dr. Ellsmere is a bariatric surgeon at the QEII Health Sciences Center in Halifax. He's an assistant professor in the Department of Surgery. He's also the co-director of the Bariatric Surgery Program, Advanced Gastrointestinal Minimally Invasive Fellowship Program, and the Surgical Skills Center. And Dr. Ellsmere will be arguing that the sleeve is the best operation.
Is that my first slide? Oh, that's better. Yeah. Okay. I was going to say there was not much of an argument here, but we might as well go through the process. But thank you. Yeah. Do I have the control? Yeah, I do. There we go. Yeah. As far as disclosures, none of them are particularly related to what I'll be talking to today. I do have some bias, though, when I start into this, and one is that. Anything that you do from a public health point of view should have really minimal morbidity, and so the idea is perception is reality is a recurrent theme through my argument today that the sleeve is the best operation for people who have morbid obesity as well as diabetes, and. We were brainstorming around this the other day when we were down at a meeting with one of my colleagues, and he brought up the story of where at his center, one of the endocrinologists, who's well respected for managing diabetes, runs a lot of trials, does not recommend bariatric surgery for his patients who are morbidly obese and have diabetes. And we all know that there's overwhelming evidence that in the morbid obesity that weight loss surgery is clearly indicated. And so I was like, what's that all about? Well, he tells me that this individual feels that weight loss surgery is too risky, and that and because of that he wouldn't recommend it for his patients. So I was kind of taken back by that, but I also appreciate that that's real. That's a true sentiment that's still out there, and many of us in the bariatric community, think that the data is overwhelming, and the data is very overwhelming as far as the benefit. But we have to appreciate that perception is reality, and we really have to, as far as choosing our operations, choose operations that have the least likelihood of having complications, because this person's genuine. This person has seen people. They've looked after people on the medical ward that have had operations that don't seem to be accounted for in a lot of our trials that are struggling with various problems, and so they're basing their decisions on their own experiences, not necessarily what the best evidence suggests, but it's something that all of us have to consider anytime we make recommendations for therapy, basically. So my objectives for the debate today is really to understand the risk-benefit profile of sleeve gastrectomy, makes it a more desirable option for many patients and providers, and kind of review the impact of sleeve gastrectomy on diabetes outcomes, and lastly touch on the impact of sleeve gastrectomy is having on some of the other metabolic outcomes, because hard to isolate just diabetes without thinking about the full flavor of the metabolic syndrome. So sleeve gastrectomy, we all know the story. It's a great story. It's only been, it's been going on for 20 years. The first sleeve gastrectomies were done for severe obesity, BMI greater than 60, and then what people quickly realized that this is just not just doing a one-stage operation, but this is a very effective operation by itself for the long term. And what's happened in the United States really over the last 10 years, that's illustrated on this table, showing the different operations that are performed, is that sleeve gastrectomy in 2011 made up about 17% of the operations that were done. In 2017, It's now 60%, and so we see a threefold increase in the sleeve gastrectomy rate. Room-wide gastric bypass goes from 36% in 2011 down to 17% in 2017. So, it decreases by almost half. And then the other individual will be debating a duodenal switch today. That's unfortunate, but if you look at the data there, that he's gone from about 0.9% to 0.7%, so keep up the good work. Okay. What is this? I mean, you'll talk to a lot of people about what's driving this, but I would argue that what ultimately is driving this is patients' perceptions and practitioners' perceptions of the risk-benefit profile. And if this slide that was recently in an article in the Trends of Endocrinology and Metabolism show that with the sleeve gastrectomy, if you look at early postoperative complications, less with a sleeve gastrectomy. You look at the late ones, and these are the ones, it's the late ones that have a lasting effect on our medical colleagues. The malnutrition, again, in sleeve, exceedingly rare in both, but just less in sleeve. You see the hypoglycemias that can be difficult to manage. You can see the internal hernias. You can see the anastomotic ulceration with the roux-eyes that sometimes can be difficult. These are low-frequency events, but when they happen, they can be a challenge to manage. With gastroesophageal reflux, it's a different story. The sleeve gastrectomy has a higher rate of gastroesophageal reflux, and that's something that you have to appreciate, and we'll talk a little bit more about that. But we're much more informed today. Here we are, it's 2019, and in the last 2 years, we've got 3 randomized controlled trials that with 5-year results comparing sleeve gastrectomy versus room-wide gastric bypass, 2 of them published in JAMA, and then the other trial published in the New England Journal of Medicine. So my colleagues are going to decipher all this data and get into the weeds and make an argument for their operation. But and I think that's great. I look forward to having a debate and discussion on that. But we have a lot of information to guide us. Now, the criticism of the trials, of course, the numbers weren't high. There's only kind of like 100 in each arm. So when you start trying to look at rare events, that gets harder to tease out, basically. So. But there are some bigger, very well done registries that have, looked at complications, and one of the ones that was published in the Annals of Surgery in 2013 looked at the Michigan experience. They looked at 3-year follow-up, 9,000 patients who, and what they showed that the room-wide gastric bypass had a complication rate of about 10%. So in the big scheme of things, that's low. Don't get me wrong, it's a good operation, but the sleeve gastrectomy is about 6.3, and then the band, of course, a little bit lower. And as far as serious, they're about the same. So again, both good operations. And then I think what this does highlight, though, is the mortality for these operations as exceedingly low. But the bowel obstruction remains the challenge with any of the bypass operations. And but the data around the bowel obstruction is getting clearer and clearer and clearer over the last decade. This is an excellent study published in Lancet in 2016, 2,500 patients randomized to, whether we closed the mesenteric defects when we did the bypass or not. And what we showed at the end of the day was we still have bowel obstructions when we close the defects, but at a lower rate. So you get, at 3-year follow-up, there was a 6% rate of bowel obstruction, whereas in the ones where you close the defects, it was 10%. So, most experts have now recommend that you close the defects, but it's still a recognition that despite the closing the defects, it's not like that bowel obstruction magically goes away. So it's real, and it's something that you have to appreciate. What about reflux? There's a lot of interest in reflux. I've sat on panels and people saying I would never do a sleeve gastrectomy because you might give them esophageal cancer. Interesting. That's a little extreme. So let's try to adopt a little bit a better understanding of reflux. This was published in the Sleeve Pass, so one of the trials in JAMA. And what you see there is that for people who are morbidly obese individuals who are undergoing weight loss surgery, they had 100 people in the sleeve gastrectomy arm and 100 people basically in the room-wide gastric bypass arm. And of all comers, so this population, about 40, almost 50% of people have clinical gastroesophageal reflux disease. at baseline. So it's very common in the population. So I don't think that the operation's necessarily giving them esophageal cancer. They're at risk just by basically their morbid obesity. But it's good. We've oftentimes, these are the numbers that we've used based on retrospective experiences, and they've actually translated into the prospective experience, which is nice. Basically, with a sleeve gastrectomy, a third of your patient's reflux is going to get better, a third's going to stay the same, and a third's going to get worse. In the room-wide gastric bypass, 2/3 are going to get better, and it says 6% there are going to get worse. What about the patients who don't have gastroesophageal reflux? About a third of them are going to develop gastroesophageal reflux after you have a sleeve gastrectomy, and about 10% are going to develop it after a room-wide gastric bypass. So those are important numbers to consider. Again, if you have a patient who's got gastroesophageal reflux, when you're trying to pick the right operation, you have to have a discussion about these numbers and factor it into your decision. How do you manage gastroesophageal reflux after you have sleeve gastrectomy? It's as it turns out, not that complicated. So the vast majority of these patients, you put them on a PPI. In my practice, I think that's like everyone's on a PPI. So but there are some risks that come with PPIs. So I won't downplay that, but it's not like the end of the world if you're taking anti-reflux medication, and that's effective in the vast majority of patients. What we know now, there's about anywhere between 1 and 3 and 10, or 1 and 6, I guess, % of patients who have a sleeve gastrectomy will go on for another intervention. And that may be a hiatal hernia repair, a revision of the surgery, or what most experts would recommend is that they go on to a root-wide gastric bypass for correcting their their gastroesophageal reflux after their sleeve gastrectomy. So that's a real concern. But the other thing that we've come to appreciate, and as far as the data that's available to inform us about decision-making around a bariatric surgery is the durability. And this publication, the New England Journal 2017, basically followed people in weight loss centers in Western United States who basically either had a gastric bypass or didn't have a gastric bypass. And why I really like their slides is that you see the distribution of outcomes, whereas many of the slides that we see that we'll see, we won't see the distribution, and the data scatter. So the typical person who doesn't have a weight loss surgery intervention, you follow them, you do everything right. We all know you're going to counsel that patient that a subset of them are going to lose weight, a subset of them are going to gain weight, and the typical person is going to be the same weight. With the gastric bypass. And with the sleeve, with some slight variability, you're going to see this variation where that they're going to lose about a third of their body weight. It's so important to see that scatter plot, though, because, again, it's perception. We all know the story of, I know somebody who had a sleeve gastrectomy and they didn't lose anything. Sure, it happens. It happens. And there are people that lose 60% of their excess weight. But it's managing our perceptions and managing our understandings, and is really important to choosing our operations. So if they go head to head, and the debate today is really about not weight loss in general, but rather weight loss operations in people who have diabetes. What should we do? And the data that most informs us is the STAMPEDE trial with the 5-year outcomes published in 2017 in the New England Journal. And the primary outcome was the glycated hemoglobin levels. And it was clear that whether you had a sleeve gastrectomy or a gastric bypass, your outcome was better than if you had optimal medical therapy, as far as this being your primary outcome. But if you delve into that a little bit more, and you look at the medications that they're on at the end of 5 years, you'll see that 45% of the people who had the gastric bypass are no longer requiring any medications to manage their diabetes, whereas that's only the case in 25% of the sleeve gastrectomy. So there's definitely some improvement there with the gastric bypass versus the sleeve gastrectomy. How the primary outcome again was not different. But that group at the Cleveland Clinic has really delved into this issue, and they came up with a very nice nomogram, and validated it on some of their internal data sets, and then used some external data sets from Barcelona as well. and published a paper in the Annals of Surgery 2017. And what they identified as the kind of 4 critical factors to consider in your patients who have diabetes is the number of medications that they're on preoperatively, whether they're on insulin, whether they have the number of years that they have diabetes, as well as their glycemic control at the time of the operation. And you pile that into the nomogram and it spits out a number and it classifies them as either mild, moderate, or severe. And what the group in Cleveland recommended was, and there's a lot of different opinions on this, but they were saying if it's severe, that the beta cell reserve has been lost, basically, they actually recommend the sleeve gastrectomy because the outcomes for either operation aren't particularly good as far as from a diabetes primary endpoint. And the sleeve being a lower morbidity, that's what they recommended. In the mild, what they recommended, what they didn't recommend, they said the Roux-en-Y gastric bypass is suggested, but they also recognized that the sleeve gastrectomy is also highly effective. And for the moderates, they went so far as to say that the Roux-en-Y gastric bypass is recommended. Again, I think if you look in isolation to diabetes and not consider perception and consider other metabolic outcomes, that's probably reasonable. What did come out of this study, though, and it's really, really important to reinforce, is that notion that if you're going to have a good outcome from diabetes, the key is to operate on them when they have mild diabetes. So it's getting to them early, not when they have what's classified as severe diabetes, because we know that you almost lose your window of effectiveness. So that's really the take-home message there is don't wait for them to be in the severe category. But I did allude to the fact that, diabetes is like any metabolic disease. There are certainly other ones that are important to consider, and patients always have a multitude of issues that need to be considered. And there's some increasing data now around, very interesting data that's emerging around NAFL and NASH and liver disease, suggesting that the outcomes may actually be better with sleeve gastrectomy than with the Roux-en-Y gastric bypass. What about renal disease? If you look at the STAMPEDE trial and you look at the baseline, the patients who had the sleeve gastrectomy, their albuminuria actually improved. It did not improve in the patients who had the Roux-en-Y gastric bypass. This comes up all the time. I had a patient who was canceled for bariatric surgery the other day by one of our nephrologists because of the morbid obese, they had some renal disease, and they felt that it wasn't their best interest because it was going to hurt their kidneys. And I actually had to call them back and said, we can have a debate about Roux-en-Y gastric bypass, but there is no debate about sleeve gastrectomy. They apologized after they reviewed the literature. So it's important. It's important that we understand these issues, basically. There's the lipids improve, the HDL improves with both sleeve and the Roux-en-Y gastric bypass, but there's some more data emerging now about the function of the HDL is actually, again, I don't kind of my expertise, but it better with the sleeve gastrectomy than the Roux-en-Y gastric bypass. And there's been some talk again about the TMOA pathway and the gut microbiome that with the sleeve gastrectomy, that the microbiome is actually more favorable than with the Roux-en-Y gastric bypass. But again, that's an area of ongoing investigation. But there's other things to consider than just diabetes. It's hard to look at it in isolation is what I'm getting at. So in summary, sleeve gastrectomy improves diabetes outcomes long term. We know that. It has a safety profile that makes it a much more desirable option for many patients and providers. And there are some interesting additional metabolic benefits that go along with the sleeve that also need to be considered when you're making decisions for your patients. Thank you very much.
Thank you very much, Jim. I didn't lay out the time frame very well when we started, but we will plan about 15 minutes for each speaker, which will leave us 15 minutes at the end for audience questions and potentially a bit of debate, depending on how contentious things get. So we'll move right along to our second speaker, Dr. Ahmed Elnahas, who is a bariatric surgeon at the University of Western Ontario in London.
Thank you for the invitation to speak today. So I've been asked to talk about how the gastric bypass operation is the optimal treatment for diabetes in patients with morbid obesity. So I thought I'd start off by reviewing what a gastric bypass procedure is and how it works, talk a little bit about how it treats diabetes, and then finally compare it to some of the other common bariatric procedures in terms of diabetes remission, and also present some of the literature that's recently been published. So this is the gastric bypass anatomy. Basically, a small pouch from the stomach is created. The small bowel is then divided, and 100 to 150 centimeter feeding limb is then attached to the gastric pouch. The separated small bowel limbs are then reattached, and this allows the bile and pancreatic juices to be diverted downstream. So how does the gastric bypass create weight loss? Well, there's three basic mechanisms. The first, which is probably the most important, is the restriction. So the small pouch size and the small opening helps reduce caloric intake. There's also an element of malabsorption with the diversion. It creates less macronutrient absorption from the small bowel. And there's also significant neurohormonal changes. Hormones are released in the body that increase satiety and help regulate glucose metabolism. And these are the few points that I had in terms of why I think the gastric bypass is the best procedure to treat diabetes. The first is that it is considered the gold standard for weight loss surgery, still advocated by the American Society for Metabolic and Bariatric Surgeons. It's been around for a long time. It's time tested. It has good, durable, and effective results. And there's also many studies out there that have demonstrated its effectiveness in treating diabetes, which we'll get into. And compared to mainly restrictive procedures like the sleeve gastrectomy, there's a lot of studies out there that show it has better resolution of comorbidities. And compared to mainly malabsorptive procedures like the duodenal switch, which we'll hear from, it offers less early and late postoperative complications. So let's talk a little bit about how it treats diabetes. Well, there's a lot of theories out there. First and foremost, it does decrease caloric intake, and that creates weight loss. And we know gastric bypass patients, on average, lose about 35 to 40% of their total weight. However, we also know that glycemic control can occur immediately after surgery, usually within a week. And that means that weight loss is not the only mechanism for diabetes remission. There's also changes in gut physiology. With the rapid small transit in gastric bypass surgery. This stimulates gut hormones, which can increase glucose utilization and insulin sensitivity. There's also improvement in the pancreatic function. There's some increases in insulin production. There's increases in hepatic and peripheral insulin sensitivity. The mechanism of this is still not known, but many authors think it has to do with the decreased intrahepatic fat that's a result of the weight loss. And then finally, there's some changes in the gut microbiota, and the mechanism of this is surrounding the bile acid metabolism and the increasing or improvement in insulin sensitivity. So these are a couple of recent prospective trials published in the New England Journal of Medicine in 2017. First one, which was talked about earlier, is the STAMPEDE trial. It's a large randomized trial comprising of morbidly obese patients with diabetes. It's a 3-arm trial. They had patients who received medical therapy, patients who underwent gastric bypass, and patients who underwent sleeve gastrectomy. But when you compare the gastric bypass patients with the medical patients, there was a significant reduction in the glycated hemoglobin at 1 year. And there's been also a recent study with long-term follow-up, 12 years, of 418 patients who had gastric bypass surgery with diabetes. That study found 65% remission rates at 6 years, 51% at 12 years. So although it is a declining number, it still shows some good durability of the procedure with respect to remission. And remission for this study and most studies out there is defined as normal fasting blood sugars and normal hemoglobin A1C values, which is a marker for long-term blood sugar control. So just to review again, these are the common bariatric procedures which I'm going to compare the bypass with, the band, the sleeve, and the duodenal switch. So when you compare it to the gastric band, and these are procedures that are performed usually as an outpatient in private centers here in Ontario, the band is really only effective in improving blood sugars through weight loss alone, and it's also associated with a higher risk of reoperation and revision compared to gastric bypass surgery, and this is due to its failure to produce weight loss and some of the band-related complications that happen. When you compare it head-to-head with the sleeve gastrectomy, it's a bit more difficult. There are still longer-term studies that are needed in the sleeve population to demonstrate its sustained remission of type 2 diabetes. But what's also important to note is that there isn't really any diversion or duodenal exclusion in the sleeve gastrectomy procedure, which is thought to be an important mechanism for glycemic control. And then finally, when you compare it to the duodenal switch, I will concede that it is slightly more effective for glycemic control based on studies and slightly more effective on weight loss, but it is significantly associated with higher risk of postoperative complications and nutritional deficiencies. So what I would conclude from that is the risk-benefit profile is much less favorable than the gastric bypass operation. Some recent comparative studies, in 2016, there was a large retrospective study comparing gastric bypass and bands. I think there's no competition here. The bypass, much better remission rates than the band. And another large retrospective study recently published in over 2,700 patients who underwent the bypass versus the sleeve. The bypass patients had a 12% higher probability of remission and 42% lower probability of relapsing over 2 years. And finally, some randomized trials that have recently been published that have been published in the Journal of American Medical Association. Gastric bypass versus sleeve gastrectomy. This was probably a landmark trial here, which compared diabetes remission after 1 year between two of the most popular bariatric procedures. They accrued 30 patients in each group, and they found a significant difference between the bypass and sleeve patients, 93% remission at 1 year versus 47% with the sleeve patients. Bypass was also compared with the duodenal switch with another randomized trial in JAMA. This time they compared 5-year outcomes in patients with high BMI. The primary endpoint for this trial was not diabetes, but 11 patients in the study were diagnosed with type 2 diabetes. 4 out of the 5 who had the gastric bypass had remission, whereas all 6 in the duodenal switch group had remission. The caveat, though, is that the switch group had way more reoperations, 45% versus 10%, and significantly more readmissions than the bypass group. So just to summarize, I kept this short. So compared to the gastric band, the bypass achieves more diabetes remission with lower risk of failure and reoperation. Compared to the sleeve, similar risk of complications, but based on some of the recent study, a higher diabetes remission rate with the sleeve patients. And then compared to the duodenal switch, like I mentioned earlier, although it's slightly less probable in terms of diabetes remission, it has a much lower risk of metabolic and postoperative complications. So I'll end it there. Thank you.
Thank you very much, and thank you for staying on time. So we'll move right along to talking about duodenal switch before we open it up for discussion and debate. So Dr. Dennis Hong is the duodenal switch guru for the province of Ontario, and he will be arguing that this is the best metabolic procedure.
Thanks, Amy. I'm always happy to advocate and excited to advocate for the duodenal switch. It's even among surgeons sort of considered the stepchild or the bad stepchild maybe of bariatric surgery, but hopefully I'll convince some of you that just as Dr. Elnahas has admitted, that it's a better diabetic operation. I have no financial disclosures that's relevant to this talk. I'm not sure how many of you are familiar with the operation. As Dr. Ellsmere said, it's not commonly done in North America or really worldwide. So this is just the the anatomy of it. And as you can, hopefully as you can see, it's actually the best of both worlds of a sleeve and a bypass if you look at the anatomy. There is a sleeve component to it, and it's basically a very aggressive bypass. So the advantages that Dr. Ellsmere and Dr. Elnahas alluded to in their talks, you sort of get both of them in a duodenal switch. During the talk, I'm going to talk a little bit some of the mechanistic differences between some of the procedures, and then how those mechanisms provide that outcome in terms of diabetes and some of the other metabolic conditions. So I want to just basically touch on, and the other speakers have touched on this as well, so, some of the GI hormones and how that changes with surgery, and specifically with duodenal switches. Another kind of hot topic is how bile acids change after surgery and how that impacts diabetes and some of the other metabolic conditions. And then another interesting topic that they've alluded to is also the microbiome. That's still in an investigative stage. I think no one really knows what happens and how that impacts clinically, so I'm not really going to touch on that. So specifically with regards to GI hormones, we know in type 2 diabetes, the big component is insulin sensitivity to tissues. And if you look at, a lot of the work has been done by Gertrude Mingrone, who's a endocrinologist based out of the UK. And what she's basically summarized and found is that gastric bypass and sleeve is great in terms of hepatic sensitivity to insulin. And in addition to caloric restriction, is sort of seems to how ameliorate type 2 diabetes early on. But if you actually look at duodenal switch and some of the work that she's done in humans and in animals, the duodenal switch ameliorates not only insulin sensitivity in liver, but it's in fact the entire body. So you're looking at muscle, fat tissue, liver, and other tissues that are important in terms of diabetes remission and insulin sensitivity. So that's really, I think, been proven by Gertrude Mingrone's lab, that duodenal switch impacts the entire body, whereas if you look at the bypass and sleeve, the main mechanism seems to be increasing insulin sensitivity in the liver. The other major differences between the other two procedures and a duodenal switch is this notion of glucose variability. So if you chart someone who's had a gastric bypass, and you give them a drink, a sugary drink, the graph will illustrate how their sugars go up, and it comes down dramatically. There's a big variability in terms of what happens to their serum glucose. If you look at the duodenal switch, which is the bottom graph, the variability is much less. And one of the proposed mechanism of weight regain, and why, if you look at someone who's had some weight regain, is that this glucose variability, the sudden increase and sudden drop, because they get hypoglycemic, they have this drive to eat, they need to eat something. And so the theory is that because there's a great variability, specifically after a gastric bypass, that increases their snacking and potentially leads to weight regain. And you don't see that great variability, this big rise, this big drop in a duodenal switch. It's much more even, evenly spread out. And so that's thought to be one of the main mechanisms of this, the outcomes in weight loss, the greater outcomes in a duodenal switch. What about bile acids? So this is a graph. A lot of this work has been done by actually the group in Laval and the French group. But bile acids is an important marker in terms of activating some nuclear receptors and cell membrane receptors for many variable things, but also glucose homeostasis. And so if you actually measure bile acid concentration, so if you want better glucose control of type 2 insulin, you want higher bile acids in your serum. So if you actually, this is a randomized trial out of Finland, comparing bile acid concentrations after a duodenal switch versus after a gastric bypass at 5 years. So a pretty long study, randomized trial, sort of the best methodology. And what this graph illustrates is that at 5 years, the duodenal switch has a much greater mean concentration of bile acids. So these mechanisms of bile acids, glucose variability, GI hormones, how does that impact on clinical outcomes, which at the end of the day is what the patient cares about and what clinicians care about. So and Dr. Elnahas mentioned, and Dr. Ellsmere mentions the trial out of Cleveland Clinic. So at the same time, Dr. Mingrone, again out of the UK, published in the New England and subsequently the Lancet, another randomized trial looking at diabetes, but this was comparing medical therapy, gastric bypass, and duodenal switch. So at 5 years, you could clearly see that the remission rate of type 2 diabetes is greater in a duodenal switch compared to a gastric bypass, compared to medical therapy. If you look at HDL, or cholesterol, it's a greater improvement in duodenal switch compared to a gastric bypass, compared to medical therapy. These two graphs are from a recent review article published in Diabetes in 2017. Again, clearly showing that a duodenal switch has a much better remission rate of type 2 diabetes. I think that that's clear to even proponents or people who are critical of the duodenal switch. I think people won't argue with that data. Lastly, Dr. Ellsmere and Dr. Elnahas have talked about complications, and that's been one of the, I think, main perceptions of why this operation really hasn't caught on, is that it's great for diabetes, but it's too complicated. Patients die, patients get into all these problems, we can't do it. And I think a lot of that data comes from the early studies, to be honest with you. The first laparoscopic duodenal switch study was out of New York by Michel Gagné, and he had a high mortality rate, 5% mortality rate in his study. That was the first paper on duodenal switch with laparoscopy. If you look at subsequent papers, and my own personal experience has been that mortality rate is very comparable to a gastric bypass, actually. The chart here illustrates, again, this is Gertrude Mingrone's randomized study, 5 years, published in the Lancet, and I'm not sure if you can see it, but if you look at the surgical complication rates, pretty low for duodenal switch. If you look at the metabolic complication rates, there's no doubt that a duodenal switch does have increased metabolic issues such as anemia, calcium, things like that. But if you actually look at the gastric bypass and some of their complication rates, the metabolic complication rates, it's offset. So if you look at that graph, if you look at the gastric bypass, they have issues of hypoglycemia. And I'm sure that you've all seen gastric bypass patients who have sort of, they tell stories about fainting, or they get lightheaded and they fall down. You don't see that with the duodenal switch because it has some of the benefits of a sleeve. It has that pylorus that's intact. It regulates how food gets down. So some of the complications that people talk about who sort of poo-poo the duodenal switch are offset by eliminating some of the complications you see with the gastric bypass. So I would say, and again, it's been my own experience in some of the newer data out of Laval, which does a lot of duodenal switches, and our group, is that the complications really are reasonable, they're manageable, and they're not this sort of panacea of people dying from a duodenal switch. So in conclusion, I think there's no doubt, I think it's clear that I think even, again, most surgeons who don't like the duodenal switch, it definitely has a better metabolic profile, specifically with regards to diabetes and other metabolic conditions. It produces better outcomes, and that I think the modern day duodenal switch, and people who do a lot of them, it's a very safe operation. Thanks.
Perfect. Thank you very much, Dr. Hong. So we have quite a bit of time for discussion and debate. So I think first I'll open it up to our panelists for a few minutes. If they had any comments they wanted to make, rebuttal points. I've seen Dr. Ellsmere scribbling furiously, so I think he's planning some attacks.
Maybe I don't think attack's the right word. I mean, at the end of the day, I always say weight loss surgery is a great option for morbid obese patients, and particularly morbid obese patients who have diabetes. And then when you start getting into whether it's sleeve gastrectomy or the Roux-en-Y gastric bypass or the switch is the right option. I think, you know, they're all reasonable options. My preference for the sleeve gastrectomy is based on the fact that it's exceedingly rare to see someone who's admitted to hospital with a complication from a sleeve gastrectomy. Perioperatively, yes, like they'll have, you know, a leak or something like that, but that can happen with any operation, and that settles all down. But I'm talking about the patient who, you know, comes in 3 or 4 years later, not admitted to a surgical service, admitted to a medicine service, and sits there for, you know, 3 to 6 months, where, you know, people don't really have a great idea what's going on, and really there's not a lot of great options for that patient. You see that with the bypass patients. It happens. It's rare, and so again, if you look at it from a scientific point of view, it's a risk, but it happens. But when it happens, it has a tremendous impact on the public perception of bariatric surgery. You just don't see those patients with the sleeve gastrectomy. There's a subset of patients who have reflux, and the ones that have bad reflux, you're going to see them in your clinic, and you're going to work them up and take care of them and that sort of stuff. But they're not on medical service somewhere. So that's my argument. That's the basis of my argument. Is that you see a lot of upside, very little downside. At the end of the day, we're only treating about 1% of morbidly obese patients who could potentially benefit from this operation. So we need something that you can roll out on a grander scale. It's a relatively simple operation if done correctly, and with excellent outcomes. So that's my rationale for the sleeve gastrectomy, specifically for even diabetes. Yeah.
Great, thanks. Anybody else from the panel have anything they wanted to add to their discussion?
I mean, my sort of, Dr. Ellsmere talked about sort of resources and safe. I mean, a sleeve gastrectomy is a very safe operation for sure. But I think, at least in Ontario, we have, and I think probably in most provinces in Canada, we sort of have a limited number of resources where we get X amount of procedures that we can do per year from the province. And so I think that only illustrates how, if you're going to do one operation for a person with diabetes, you want to sort of pick the best one at that time. And so if the debate is, which one do you want to pick, someone with insulin and things like that, my personal opinion obviously is that I think a duodenal switch is better. Again, because in Ontario, we have limited resources. We have X number of cases per year. We don't get any more than that. And so, you want to sort of maximize the best operation, I think, for that one person. And so they don't have another operation down the road, basically.
Thanks. That actually was a question I was going to ask the panel, which is there potentially public health benefit to considering the most effective operation, especially as we look at one of the merits of bariatric surgery being long-term cost savings to what we already know is a stretched healthcare system in Canada. So I think Dr. Hung is kind of
and I want to say there's a poster out there I saw from Newfoundland. I don't know who that person. Oh yeah, great poster actually. I wanted to talk to you actually, but it was on sleeve and hospital costs, and I think it wasn't just diabetics. Just looking at the poster, but in Newfoundland anyways, it costs more. If you do a sleeve. So
Costs more than what?
Post-op.
Like sort of as a pre and post, I believe, study, and
Costs more than what?
Yeah, it was a 5-year study. So I mean, pretty good. It's a pretty long study, and so that just goes to the point about sort of limited dollars, limited resources in Canada. I mean, it's not like we obviously don't have private medicine, so you want to pick the right operation that one time.
I'll just repeat what was said for those of you who are quite far away in the room, which is that the poster showed that in Newfoundland, after sleeve gastrectomy, to start seeing cost benefit to the healthcare system, it took in the range of 4 to 5 years before there was cost savings as a result of weight loss surgery. And I think we see very variable numbers like that in the literature of how long does it take before we kind of make up the value of what the surgery cost us. I would actually argue that may be an argument that goes a little bit against a sleeve, because that's also where the weight regain is really starting. But I'll leave it there. I'll open the questions to the audience. If anybody has a question, a comment, please feel free to step up to the mic. It's this very long room, so we can all hear each other.
Hi there. I do have one question for Dr. Hong around the UK study and DS. Were they all single stage through that study, or were some of them two-staged? And do you think there's a difference in the outcomes for that approach?
They were all single stage, but the Laval group has looked at a single stage versus two stage. And at the end of the day, that doesn't seem to matter whether you do it a single stage or not.
So you're finding the long-term effects on diabetes no different?
Correct. Yeah, that's what the Laval group showed. Yeah.
Thank you. We'll just go to the far microphone, and then we'll come back to this one. Sir?
Thank you very much for the presentation. My question relates to the pre-diabetic state as opposed to diabetes and the differences in the response. That was question number one. And if you would permit me for a second question, that would be great.
We'll call it a follow-up. Does anybody want to answer that?
There have been recent studies. I think one was published recently in JAMA, looked at early onset versus late onset diabetics with respect to medical management versus bariatric surgery. They found that bariatric surgery was more effective in the early onset group. So younger patients, early onset diabetes, better chance of diabetes remission in that group. Yeah, for sure.
Coming from the pediatric area, one of the concerns is that the perception that the sleeve is so easy that anyone can do it. You don't really need a bariatric surgeon. And the pediatric surgeon have said, well, we'll see one and then we'll go ahead and start doing them. And I think over time, the results and the complication rates, et cetera, as it moves away from bariatric surgeons to general surgeons and pediatric surgeons, will change the complication rates, will change the results.
So I know at Sick Kids, they have the STOMP program there where they do offer sleeve gastrectomies in the pediatric population. I don't think they've done any gastric bypasses, but I think a sleeve gastrectomy in that group can temporize sort of the situation until they can sort of declare themselves a little bit when they're older in terms of if they need any additional procedure.
At the Sick Kids, 40% of their surgical interventions are bypass.
Oh, really?
Yeah. I come from Montreal at the Children's Hospital where we've done 9. 8 of them have been sleeves, and 1 of them has been a gastric bypass.
Oh, interesting. I was mistaken then for sure because I thought.
I'm not a sleeve expert. Maybe Dr. Ellsmere is more of an expert at that, but I think that's the perception that sleeves are easy to do. But I think that there actually are nuances to doing a good sleeve, and so. I know, particularly some of my American friends, a lot of, just any general surgeon can do them and things like that. But, it's not the easiest operation, number one, in people who are overweight or obese. And 2, there are technical nuances to actually doing a sleeve that can make a big difference, actually. So, yeah, I don't know what your thoughts are, Jim, but I don't think it's an easy operation.
No, I would add to that, too. I think we see some of the popularity in the U.S. is in large part related to the ease of learning to do a sleeve. But I agree 100% with Dennis, and we might be a little bit biased. We both practice in Ontario, where bariatrics only happens in centers of excellence. But I agree, there's nuance to doing a good sleeve, so not all sleeves are equivalent. That is very, very clear. If you can't handle a sleeve complication, you probably shouldn't be doing a sleeve, and I would argue that sleeve complications are actually often quite technically complex to handle. And the third thing I would also say is that if you can only offer one operation, because you're right, the average general surgeon can learn to do a sleeve, they're unlikely to pick up a gastric bypass on their own, you are probably not making the best choice for each individual patient, because we know there are very specific patient considerations that help us choose the best operation. And we've got one trick up your sleeve, that's the one that everybody gets.
Thank you.
So we'll move on to another question.
Yeah, thank you. I'm André Chernoff from Laval University. Thank you for an interesting debate. Mm-hmm. My colleague, Dr. Alberto, has published data showing that in insulin-treated patients, the rate of remission after a sleeve is 22%, whereas in the switch, it's 81%. So the switch is particularly effective for the severe diabetes. My question was to the panel if they had an opinion on the role of, or the potential interest of the single anastomosis duodenal switch as some sort of compromise.
Yeah, I mean, we at MAC, I know at Laval does them as well. We do the single anastomosis as well, and we have a randomized trial actually looking at that right now, and we don't have the results of that yet. But I mean, my sense of the single anastomosis is that it's not as good as a full duodenal switch, both in terms of weight loss and in terms of type 2 diabetes remission is what we have found so far in our randomized trial, just looking at the data. And I think at the end of the day, it's sort of going to come out in the middle between a gastric bypass and a full duodenal switch. And I talked to Laurent about this, and I think he sort of feels the same way, and that's his sense of where that's going to fit in. But I mean, we do them. I think it's a reasonable operation, but you know, we'll have to wait for the studies to come out, though.
Thank you. We'll go back to the far microphone.
Hi, I just wanted to follow up on that comment about cost savings. So I'm Laurie Twelves. I'm a professor at Memorial University and been doing a lot of research on our bariatric population since we started the program in 2011. And I guess one of the things I think we need to be careful about is the difference between cost savings and cost effectiveness. Because often governments are looking for cost savings. So actually even publishing that data and putting it in a poster, I thought, oh, great, here we go. There's going to be, people are going to be jumping on the bandwagon saying, oh, we're not saving money with bariatric surgery. But the real issue here is actually what are people back in the system for? And people are back in the system because they're healthier. They're back in the system for a joint replacement, a knee or a hip replacement, a hernia repair, a gallbladder removal. Several women are getting pregnant. So actually, they are back in the system, so they're costing the system money, but they're actually back because they're healthier people. In terms of cost savings, and this particular poster, we're going to be integrating medication data into it as well. I think when you put the full picture together, you will start to see some cost savings. So for example, if you have 30 or 40 or 50% of your population no longer have diabetes or hypertension, then you've got the cost of the drugs as well. But you do have to go quite a ways out to start seeing that kind of return on investment, although you'll see cost effectiveness data showing itself in the early years because patients are actually healthier.
Thank you.
And I think that's probably independent, that will probably be the same across most of the surgeries.
It's a very interesting observation, and I think it's perspective we don't always hear when we talk about the cost savings data, because it's usually just about how many people continue to be followed for diabetes, how many patients are managing diabetes-related complications, et cetera. So thank you for that comment. We'll go to this mic.
Hi. So I really like also those debates because it's like you're fighting from one treatment against plotting against the other. But I saw because we have more options, I think it's important that we start thinking like the medical counterpart. You don't have a drug that is one size fits all, and we shouldn't have a surgery that is also one size fits all. So you spoke about if you have to take one, but you don't have to. This is why in our center we prefer to start with the sleeve because you have options to transform it as a second stage. So when we touch the subject of the second stage, it has the same result, it's been proven, but there's one other option, is the patient selection that Amy, you spoke about. Patient selection is important. If you start with a sleeve, with all the preparation, because we do the same preparation for every surgery anyway, so you're sure that this patient is a good patient, he understands and everything, but then he stops just showing up to the appointments. Well, if he just leaves and never show up again, being stuck with a sleeve is not that dangerous, but it is with a malabsorption. So we make sure that the patient is compliant, and then when the weight loss stops, then we go back and do the second stage. So if it is, then the second stage would be if it is diabetes, we would prefer the duodenal switch, that's better results. Of course, if you pitch that, well, it's higher risk, well, the same is true. If you say that the bypass is less efficient but safer, the sleeve is less efficient and safer than the bypass too. So the same argument would fit. So we start with a sleeve, but if the patient develops severe reflux and still diabetes, then we would switch it to a bypass. Mm-hmm. So the sleeve is a very good start, both for options and also assessing the follow-up.
So that, as you know, Dr. Hong reflected on, there's a lot of naysayers for duodenal switch due to risk. Essentially, you're screening them somewhat aggressively. And we'll take, I think, one last question.
I think Dr. Beausoleil was like a plant for me over there. Thank you very much. Whatever proceeds I get from this debate, I'll share them with you.
I have a comment about that, though. I don't think a sleeve is just a benign operation, though. Like if you do a sleeve and they get lost to follow up, and you say, well, they had a sleeve, it's okay. I mean, there's more and more data about reflux, like you mentioned, and there's more and more data about Barrett's with reflux. And even with some of the nutritional complications, yes, you don't alter the GI anatomy in a sleeve, but if you look at some of the data on sleeve long-term and some of the metabolic complications, they do get iron deficiency anemia. They do get calcium, hypocalcemic, and secondary hyperparathyroidism. So, I think that notion of, well, they had a sleeve, it's okay if they don't come and see me, or we don't follow them up, I think I don't think it's right. It's not a benign procedure, a sleeve.
No, it is not. I was not saying that we should let them go. I mean that it happens anyway.
Yeah, I agree. Yeah.
So they move, then they don't show up again. So when you have that, I start with bypass. So I have more than 500 bypass done, and then sometimes they show up 10 years after, and we cut a scurvy this year, deficiency in vitamin C. So this patient, very intelligent, he swore that he would come to follow up, but then he showed up with canes, glasses, no teeth. So I told him, well, this time you stay with me, otherwise you'll die. So it happens. Of course, we never plan. We make them sign that they agree for lifetime follow-up. We don't release any patient in our center, so I have follow-up for 15 years now. But some just stop. So I'm meaning it's not safe to leave with a sleeve, but it's the lesser evil of the three.
I just wanted to comment on something.
Sure. And then we'll take one. So quick comment and then one last question.
Yeah, just something sometimes people don't appreciate is reversibility. So a sleeve gastrectomy is actually an irreversible procedure compared to a gastric bypass, which is still a reversible procedure. So when I compare it head-to-head, bypass versus sleeve, I think the bypass would offer the best first opportunity for the patient to treat what we're trying to treat. If they develop any sort of complications, long-term complications from the bypass, there's always still that option to reverse them. Whereas the sleeve gastrectomy, again, you're sort of limited to either performing a duodenal, converting them to a duodenal switch, or not having any other option to sort of treat any problems with the initial procedure. So, and for that reason, again, I think the bypass is, it's a reversible procedure, durable procedure, and would be my sort of first choice in a patient coming in with new onset diabetes with a sort of a BMI.
But if you do reverse a bypass, you have a full weight regain.
What's that, sorry?
If you reverse a bypass, you have a full weight regain.
Absolutely.
Yeah, I mean, but it's very rare, obviously, to require reversal, but it's still, it's something that can happen, right? So.
But those that I revise them into sleeve, not just anatomic.
Yeah. But it depends on the reason for the reversal as well, right?
You could have just had the sleeve to start off with.
We have 2 minutes, and I see him being timed at the back, so we'll go with one last quick question.
Sorry, I just wanted to check if the panel had any insights into, aside from kind of the complications, which are obviously rare, has there been any look at the difference between different surgeries and patients' kind of quality of life afterwards? Any kind of data on quality of life indicators with the different surgeries?
That's a great question. The the Stampede trial, published in the New England Journal, the 1 year, 3 year, and 5 year had quality of life and across 7 domains, and it's a good point to point out that compared to medical therapy, both the sleeve and the room-wide gastric bypass for the patients enrolled in the trial had improved quality of life, and it's almost a good point to end on, because really at the end of the day, why we do any of these operations is not for metabolic outcomes. It's about quality of life, and it is clear in that trial statistically that you'll see across 7 domains of their life improvement, and that's really the justification for either operation. There was no statistical differences between the sleeve gastrectomy and the room-wide gastric bypass. But.
Dennis, do you know if there's anything for duodenal switch?
The the graphs I showed about the Lancet trial from Gertrude Mingo, and she had a quality of life also in that study at 5 years, and they used the SF-36, and the overall score was the same between people who had duodenal switch and people who had a gastric bypass. There were some differences within the domains itself, but overall there was no difference at 5 years.
Good. So I'll stop now, conclude by thanking our panelists for the discussion. Thank you for everybody for participating, and that will end the session.